Hi, everyone. Thanks for coming today. So Charles and I are going to sort of co-present the first section of the panel. We'll each talk about 5 minutes. Charles and I actually have worked together for quite a long time. I won't say exactly how many years. But the most recent thing that we did together was to join UC Irvine in 2009, and we started the Informatics department there. So it was really fun to build that department together with Charles. I'm going to touch on some of the highlights of things that I think were most impactful during that time. And so one of the first things that we did was to start what we refer to as an evolution in analytics at Irvine. And so we brought in Tableau to use as our business intelligence and analytics platform. And we were actually the second healthcare customer for Tableau, Seattle Children's being the first. And what we did was to leverage basically the business analysts and clinical analysts that were already working out in the clinical departments and using mostly Excel to do their analytics. And so we did a sort of a decentralized building of dashboards. We trained them on Tableau centrally, and that what our team did was to provide the data centrally that fed the dashboards that were built by the experts. So that what we did was to allow the expertise to handle the parts that they were best at. So, in informatics, we managed the data, and the business side knows how to use their data to make the best visualizations. And the outcome of that was that we were able, especially with the quality department, who was our first and strongest partner out on the clinical side, we were able to free up time for the analysts in that department to be able to concentrate on improvements. Right? Instead of just spending all their time gathering the data and presenting it and redoing that month after month, they made the presentation once. I mean, they developed the dashboard once, were able to reuse it, and we provided the data centrally, and it refreshed every month, so that then they could use that data to go out into the hospital and improve the quality of patient care and safety. And so a more recent thing that we've been working on, my team, is to develop a quality measure engine. And so I'm sure all of you are facing the workload of having to code increasing numbers of quality measures from, all the agencies that are asking for that information from us. This is driven by the move to quality-based, value-based clinical care. And so what we've done is to develop this engine that sits on top of our enterprise data warehouse, and it's what we call a parameterized engine, in that what we can do now is to take in the definition of the cohort, and then the definition of the time range, and then what measure you want to use, and run that through the engine really quickly. And so it allows you, once you code, all of the measures, it allows you to tweak them to get the best possible outcomes. So not only can you tweak the cohort, to represent, the different subtle variations in definition of cohorts. For instance, I don't know how many of you are participating in PRIME, but those cohort definitions are very complex. And then additionally, on the measures end, measured definitions from different organizations can vary very slightly in their specifications. And so we can do a little tweak in that, and then process things much more rapidly, so we can be more efficient. We provide support from my team for clinical research, in addition to supporting quality and patient safety and hospital operations. All data provision is centralized at Irvine. And so we are the honest broker for UC Irvine, so that anyone who's doing an approved, an IRB-approved clinical trial, comes to us and asks for the data, and we work with them to provide that data in a secure environment that we call My Research Portal. This provides a virtual environment in which the data sits and in which statistical analyses and other analyses can be done right in that virtual environment. And then more recently, I sort of alluded to my passion is sharing data. At the UC, it's been really fun because the five UC medical centers have been working together on data sharing initiatives for 7 years now. And so the first initiative was the UC research exchange called UC Rex, and that was kind of a federated data sharing where, we leveraged data warehouses, individual data warehouses at each of the UCs, and then had a central user interface to allow us to do cohort counts, so that we could see, if you had an idea for a study or, wanted to do collaborations with somebody else, you could enter cohort criteria and then get counts from each of the other UCs about how many patients there were there that matched what you were trying to do. And so more recently this year, we've started a centralized data warehouse initiative where we're ready now. We have that level of trust and capability to now bring the clinical data together in a central location. And UCI is hosting that, and I have the honor of directing that initiative. Okay, and then some exciting work that started when Charles was at UCI. We have been bringing in physiological monitoring data at 1-minute intervals for 4 years now, right? So we have 4 years worth of data that we've been storing in a Hadoop system, which Charles built about 4 years ago now. And it was one of the first, if not the first Hadoop system to be used in this way in healthcare. And so what that is allowing us to do is to use that data to create better, improved algorithms for detecting things like patient deterioration in the ICU that Dr. Wilson was talking about earlier. So it's sort of a complement to the EICU that he described, in that, the development of algorithms occurs, in this system, and then we bring them into the larger EICU system to be worked on and responded to. And Charles will mention a little bit more about that. So we're looking at patient deterioration, and as Dr. Wilson said, we've been also working on a code blue algorithm that has about 27 different data elements. And you can talk to Charles about that to get some details or ask questions about it later. And then also an algorithm to detect sepsis. And then some things that we've been working on at UCI for real-time monitoring have to do with blood product utilization, trying to manage that and sort of drive people to use the policies and processes in place in order to ensure that patients are getting blood at the right time who need it, and then those who don't are not getting blood unnecessarily. And then we've also been able to help out on the billing side of things. Dr. Wilson mentioned our less than epic EMR that we've had. And so one of the things that we've been able to help out with is to identify incomplete documentation in the EMR that would be especially impactful for billing purposes, and to help identify those and get those completed. And then I'm going to end on this slide. It's a still shot of the graphical user interface from the system that we've been co-developing with Charles and his company. And this is the system that would come up in the ICU and monitors to help track patients and to help alert on patients who are deteriorating, starting to go down, and to tell them, sort of keep track of the, the major statistics. And there's an indicator, a code blue risk indicator. In this case, it's low for this patient. And then some other information is included in the interface. And I'm going to switch over to Charles now, who's going to tell you, some more interesting stuff about this.
Thanks, Lisa. We'll see if it's interesting or not. So I'm going to do my part on the clinical academic side of things, not a commercial. And thanks for throwing that up there. Dr. Wilson also showed you a visualization. There's a professor at Kenneman. His book is Thinking Fast and Thinking Slow. And because we're talking about the impact in clinical environment, we always want to invoke what's called a systems type 1 response. You saw that orb. You take a look at that orb, and you know at a glance what's going on with that patient. And the same thing here, infographic representation of data so that a clinician can impactfully take a look and then act on it, where they're not having to, roll and scroll and looking at tons of data and so forth. So, as we kind of, move into this, new realm and so forth, and we're presented with various types of data, we really have to have the ability to, ingest it and do something with it. And it's not just EMR initiated data. We're now, what's been described as bringing in, physiological monitoring data, smart pump data, ventilator data. Most don't realize it, but there's over 40 parameters that come off that ventilator, and even tracking peak airway pressures and so forth over time. So there's a lot of good data there. Smart pump data and usage and so forth. And if you think about everything external to the hospital as well, even like for helping COPD patients and juvenile asthmatic patients, temperature, humidity, pollen count, air quality, and so forth. We really don't have any place for that really in healthcare, as it exists. And this is kind of the reason, Lisa and I took a look at really the technologies behind, Facebook, LinkedIn, Twitter, Yahoo, and so forth, some time ago to bring them in. Another thing that I'm really an advocate, or evangelist, if you will, is I believe clinicians really have to understand technology to a point, because if you do not participate in technology decisions, technology will be enforced on you. So it's really, really important. I know we do a lot of work with configuration and where things go, but the more you understand underlying technology, the better you are to, work with developers and make suggestions and so forth. So really where we're going now, and UCI, joins, Geisinger. Geisinger is a big one. Mercy Health have incorporated this within their EICU environment. And there's several other, academic institutions out there that are doing this. And what it's called is a Lambda architecture. We're very much familiar with, bringing in data and storing it in a tabular relational environment, such as our EMR, our data warehouses. But there's another aspect to that, and that is the ability to take streaming data and do something with it. And in our case, to be able to take all of that physiological monitoring information as occurs, ventilator information, as well as laboratory systems as it comes across, and then run it through algorithms and so forth, and then present back to clinicians whether patients deteriorate or not. And I will say, in regards to algorithms, if you're working with somebody that has the magic algorithm, if you will, make sure you understand the math behind it. Many folks are not willing to really disclose that, but you have to. And there's a little secret, math is not patentable, so an algorithm is math, so you really need to understand it. And when we talk about, adoption and so forth, which we'll probably get into here, clinicians have to understand that. So I just want to let you, kind of get a semblance of, some of the technologies. We'll go through one more really quick, and then I'll sit down. So, and Dr. Wilson brought up, and one of the questions out there about a learning data ecosystem. There's a academic medical center that uses this technology as part of their medical school program. So their medical students from year one are involved in data analytics, are involved in data, so that at the end of their 4 years, not only do they graduate with an MD, MS or PhD in data science. So, the more we bring this in, the better. And it really doesn't work well within a EMR environment. So the idea here is to be able to ingest data of all types that we, kind of talked about, land it into a place, and then, which we'll call, a data lake, and then bring it up to data ponds, if you will, for various applications and so forth. But again, and then, present to clinicians, not alerts, but as Dr. Wilson, described, information. I will just really quick digress. In the late 80s, early 90s, Karen Stouffer's here, she experienced it as well. We worked with Dr. William Shoemaker, and we developed predictive algorithms and so forth, especially around hypovolemic trauma patients, and we kind of made the mistake of calling it prescriptive analytics, and it didn't work out very well. Nobody back then and nobody now really wants to be told what to do, but they are appreciative of information at the right time to make clinical decisions. So I think we have a really good opportunity, as far as clinical impact, to present information that's actionable. And again, that scenario of nurses in a trauma surgical ICU or medical ICU, nurse surgical ICU, doing their damnness for their one or two patients and helping out of their others, you can miss things. And that's why these are very much adjunctive to the practice. The EICU, algorithms around it are adjunctive. They're not, and they shouldn't be perceived as a threat, though it's still a little bit of an adoption issue, as we all know. So I'll leave it with that. Ellen's going to be coming up next and talking about the great things she's doing at UCLA.
Hi, everyone. Happy to be here. Okay, so I'm from UCLA, a little bit up the street. Happy to be here with our sister UCI. I think you probably have heard of us and know what we're not doing with EICU. He didn't know I was in the audience. No, just kidding.
Your team will drink the Kool-Aid.
I'm sure we will. So I'm going to talk a little bit about how we take all this great information and how we're trying to actually get it into the hands of the clinicians. So the project that we're working on is trying to enable mobile solutions and enable alarms and alerts to go directly to the right clinician at the right time, with the hope of enhancing care team collaboration and eventually getting a lot less reliant on our sort of dumb pagers that doesn't have a lot of intelligence with it. So this is a process, and I was saying earlier to Brenda that things, especially at UCLA, are very slow to make changes. So we started a couple of years ago trying to get the plumbing together to enable all of this. And the first major step is to get smartphones in the hands of our nursing staff. It takes a lot to research and to select the right form factor. As you can imagine, there's tons of security challenges and mobile device management solutions, so that is a first big step for us. And then we're going to build off of that and enable secure text messaging between clinicians. We will be supporting both enterprise phones that we supply the nursing staff with bring your own device phones, which most of our physicians and many other clinicians will carry. So we want ease of communication with either one of those. In order to implement text messaging, we don't want to do that without a very robust directory. So we are building a connection with our AD to be able to have all our staff members in the system, and also ADT integration to have all our patients in the system. And then even deeper than that, we are building an integration with our care team, which is in our EHR. So that way, when you search for a particular patient, you then don't just get the patient information, but you see who are all the clinicians, and you could then decide who you need to communicate with to share all this wonderful information that they were, and other things, but examples of what they were presenting. Once we have that building block established, the next big challenge will be to enable alarms and alerts to go to the right clinician at the right time with the right level of priority. So I'll tell you a couple of the use cases that we are building. We're implementing a patient portal, so all of our patients will have tablets at the bedside, iPads at the bedside, and they will be able to push buttons for what assistance they want. So in this case, if the patient needed hygiene or toilet assistance, that could go right to the nursing assistant, so it doesn't, the RN does not have to worry about that, where if the patient is having pain and pushes that button, that could go directly as a high priority message to the right nurse's phone. If that nurse happens to be on lunch break and unavailable, it would go to the nurse who's covering for them. If the nurse just didn't respond in a timely manner, it would just go to their escalation point as well. Another use case we're working on is nurse call integration. So in this example, it's a bathroom light. The cord in the bathroom would be pulled. And along with that message would come patient information, so you could include the diagnosis, the age of the patient, any sort of what you would like to go with a message like that. You could include the fall risk, so you know how quickly you might need to run to that bathroom, and you can send it to the right person. So if this message was set up to go to the RN, but the RN knew the nursing assistant was available, they could just send this whole message with context right to the nursing assistant to be able to help the patient quickly. And then looking toward the future, these are some other integrations we're going to be working on. Critical labs, stat orders, early deterioration scores, bed management notifications, reminders to the nurse to go reassess for effectiveness of pain medication, alarms and alerts from physiological monitors, and code blue notifications. So that is just a little snapshot of what we're working on at UCLA. I'll hand it back to you.
I really, really love how we went deep in the data and then brought it to the bedside, and everything that goes on in between that is truly not easy. So thank you very much. So this is the question and answer section. I'm going to kind of throw a lob over to the team, and I trust you guys will go back and forth with it in your discussions. One of the first questions that I have for the panel is, what has been the most challenging part of the initiative that you're working on today?
Go ahead.
I'll take that one, I guess. So everything at UCLA is challenging. It's very hard to get decisions and to make purchases, and to, once you actually finally make a purchase, you think you're home free, and then you're just starting out with the design review and the security review, and it's just feels like roadblock after roadblock, so you have to just be constantly moving forward. So I think bringing in new technology, transformative technology, is just hard and requires just constant pushing forward one step at a time. So I think for me, it's just ourselves. We're really hard.
Can you guys hear me? Yes. Okay, I'm prepared to answer that. At least I think I am. So, and it has to go back to, adoption, kind of what I talked about. And I have pretty much two case studies that are very similar. Everybody remembers barcode med administration, right? And you remember, whether it be, 10 or 15 years, whenever you guys started doing it, remember how resistive everybody was until each nurse had that moment where they scanned something and it beeped, and they go, oh my God, I would have given that. The same is true with these algorithm, developed messages and so forth. So like we both, described, getting, a message that, says in the last half an hour that, the temperature's, gone up, blood pressure's dropped, the heart rate's increased, these labs have come in, and you really need to, do something. We still get a little bit of, hey, that's my job. My job is to stay on top of that. And until the staff has that moment where they go, oh my gosh, I would have missed it. It's kind of like the same thing. So I'm going to have to say the most difficult thing, initially is one, getting across not so much the technology, but, what's behind these models. And they're, again, it can't be a black box situation. And then it's got to be useful. Just flashing out, your patient's in trouble or whatever is not very useful, but actually providing, some information that folks can, take an action on is.
I might just add a couple things. The first is, I can remember many times in my career where I had a really good idea when I was like a medical student or resident, and I would tell somebody above, hey, what do you think about this? And no, that's like, yeah, don't waste your time on that. And then, oh, okay, well, it must not be that good of an idea then. And then all of a sudden, like a couple years later, some company's making $1 million on the same idea. So I think you've all had that experience, right? So I think as we go to different meetings and we learn things, if it looks like it resonates, like it makes some sense, then we should embrace it and figure out how can we get it into our system. So at UC Irvine, I'm really lucky because of the two people to my left who just met our UCLA colleague, or I have just now, but with Charles and Lisa. So if you have an idea, you just go with it. And sometimes it may take a little while till you can get the great partners. I'm lucky we have some great partners, but there will always be naysayers. There'll be the financial naysayers. There will be all these roadblocks. But if you've got a great idea, just keep working with people, and ultimately it's going to happen. Now, what Charles just said, I'd like to give an example of what Charles just said about that. About you didn't really like the barcode till you saved somebody from it being, and people will push back. So when I was visiting Emory's EICU, and they had just deployed it. They have 5 different ICUs that they have 4 that have the EICU in place, and they had just deployed into the cardiovascular center about 2 weeks prior. And initially, there was a lot of pushback from the nurses and the nurse managers because they thought they were so darn good with everything. They're like Emory Health, really good cardiac. And then they just discovered in that last week, they had a couple patients whose lives were saved because of the ICU. And it just went from they were totally against it to now they were for it. The problem at Emory was they didn't do what I said before, is if you really do get good buy-in from the beginning, they didn't do that work in that cardiovascular unit. They did it at other places. So they didn't get everybody together to begin with, because once you kind of see it and you look at the data, it's kind of, it's really there, but they kind of pushed it on them and they had pushback. But then once they had saved some lives, then there was great buy-in. But the overall message is the hurdles are only for those who stop. So just if some of these things that we're talking about seem interesting to you, please email us and we can help give you some references and start thinking about how you would deploy it. And then let's partner everybody out there with us. One of the great things here is the more that you interact and share ideas with other people, really the stronger the whole system is going to get, as opposed to just, well, we're going to keep this really good idea to ourselves, and then we're keeping it so precious a guard and nothing ever happens with it. So I think I would invite you to ask us, and we'll be happy to help.
Thank you. Great. Lisa and Charles, to start us off, what are some of the data governance issues that you face starting these kind of initiatives?
Okay. So, I'm good? Okay. Well, let's start off by saying data governance means many different things to many people. And so one aspect of data governance is around governing the quality and integrity of the data. And what do we mean by an encounter type in our hospital? How do we stratify those? And then, so another aspect of data governance is governing, access to data and prioritization of requests to receive data. And so I think for us, the biggest obstacle to having, good data governance or, improving data governance is the lack of time for people to get together, to talk about that and make decisions, getting the right people together. And so even though I think everybody would agree if you talk to them individually that, oh yeah, that's an important thing to do, when you try to, convene it and, push up the priority enough so that you actually get to have a committee, it seems to get pushed down. And so, we finally got to the point this last year, sort of in conjunction at UC Irvine with our move from one EMR to another, so moving to Epic, we really needed to get a handle on our data and understanding, what different things meant and creating, an umbrella data dictionary so that we would be able to make that transition seamlessly between the two EMRs. And so, I think often, there are sort of, I wouldn't say, I'm not saying that there's one big obstacle, but that people maybe don't perceive how important data governance is until they start doing it. And one of the ways that I've found that, so one of the things that have come out of us doing data governance is that we've shown by defining our data better, we are able to get better scores in our quality measures because we're pulling in the correct data now, all in one group. Whereas, if we hadn't grouped things correctly previously, then we might have been missing, components that were needed for a particular quality measure. So I would say that it's a continuing process to do data governance, but it's worthwhile, and by starting it sort of iteratively, maybe on a project basis. So we started by doing data governance related to quality improvement. You sort of chunk it, do it in little pieces and show what the benefits are. Then you can get started.
Yeah, just one comment. What Lisa describes works well. Many organizations take on data governance as a religious effort, pretty much, where they bring on a large staff, data stewards for, all across the board. It ends up being a, 1.5 million a year endeavor, and it usually goes to heck really quick. But if you take it as a smaller approach, and that quality measure example is a really good one because you want your scores to be accurate. You want them to be as high as they can as well. And I think that's probably the the best way to demonstrate how data governance actually works.
Great. Ellen, Dr. Wilson, do you have anything? Okay. Ellen, this is for you, being on the front line, and maybe Dr. Wilson a little bit more too. Are you at all concerned with alarm fatigue with all this disparate data coming in?
Yeah, we talk about that a lot. I think, speaking of governance, we definitely have to have solid governance around what alarms and alerts we send, and some guidelines surrounding texting. However, I would sort of argue that everything that we do send to the phone, the nurse is being notified about anyway, so as long as we don't double it up, and as long as we can offload some of the things that would go to the nurse to other skill levels, I think that will move us in the right direction. And having the ability to set priorities over things. Right now, everything sort of comes in at the same noise level, but if we can set low priority things that don't make any noise and high priority things that will make you respond immediately, I think that will move us in the right direction as long as we're very thoughtful about it.
Makes sense. Dr. Wilson?
Great question. I think obviously there's a national mandate to try and decrease alarm fatigue, but when we walk into the patient's room and they're on the floor dead because we did not round on them enough, we did not know that they disconnected from their, they got out of bed, whatever it was, that's a much worse problem than alarm fatigue, we would agree, right? So how do we reconcile the need to have early actionable data and not overwhelm ourselves? And the picture that Charles provided of the human anatomy, where that was sort of a black and white type of a picture, but you can envision where if all those systems are doing well, that they're all in a green color, and if they're not doing well, certain systems would light up in different color. That could be a very robust way of characterizing the severity. Then you saw when Charles gave the Clearsense data that the last 2 minutes of what was going on. So it's not just you just got pinged right now, but this has been maybe going on for the SATs have been low for more than 2 minutes. That's a little bit more meaningful than just the fact that the patient's having some movement artifact or got disconnected or something of that sort. So there are ways of, it just takes a little bit of thinking and agreement. And just as we must be stewards of the data in the data repository, we must be stewards of the decision-making around the boundary conditions of what is or what is not an actionable alarm. And there's ways of putting soft chimes on certain things and more robust type of noises that have meaning to people. Just as we all are used to hearing that pulse oximeter go as the SAT's decreasing, that's not a good sound. Right? And so we know what that means. Some of the other alarms, you may be in a patient's room and you've got 2 or 3 other alarms, you're not sure, is that the water heater alarm going on there? Or is that this, or, those are problems we haven't solved yet. But we're on the mission. I think we're on the right track. And we have to put it in, you put the data together in a meaningful way. I think those are some of the solutions.
Great, thanks. This is for Charles and Lisa. What's been your experience with organizational adoption of the streaming technologies that you've been working with?
I think when we first started, when Charles was still at UCI and he was building, the first Hadoop instance in healthcare, that the technology was a little bit ahead of the readiness on the clinical side. And we didn't have Dr. Wilson yet either. And so I think it takes somebody with, that vision on the clinical side to be there, to be, your champion, to be able to move the dream of, that the technology can bring into the reality of, using it in a clinical care setting. And so I'm not saying that you need to necessarily, wait until you have your champion to begin, but there can certainly be some frustration with beginning, before you have a clear champion in place on something, that's maybe a little bit ahead of the curve.
Yeah, I would agree with that. On the operational and financial side of streaming information, if you talk to and this is what I found, just over the last year, if you talk to the CFO and as the course of care is progressing, if through these streaming technologies, you're able to build a billing profile that then that could be adjunctive to the coder to ensure that when that bills drop, they get their maximum reimbursement and they get it without any denied payments and so forth. That perks some ears. So what I'm finding just in the last year or so, although the clinical is really, really important, the financial is really, really, really important. And as well for the folks that work within operations and patient throughput, if we know where patients, clinicians are at any given point in time, as far as what they're doing, where the bottlenecks are, what are the lab turnaround times, what are the radiology turnaround times in a real-time nature, then those types of things can be addressed. So, coming out of the, the clinical realm, which has been the most difficult, to be honest with you, for adoption, into the more operational and financial, where there's a financial impact. And, Dr. Wilson's success and many others as far as the EICU goes, is because they're able to get more patients in those beds, and that is the ROI. Although we're improving patient care, we always have to demonstrate the ROI. So that's where it gets a little bit more difficult for adoption.
Yeah, so the streaming data is really the exciting part, right? It's like, how do you deal with live data right away, as opposed to the old-fashioned way where it takes a little while to churn it and make some sense of it. So when the streaming data first comes off, it's kind of like snowflakes. All this stuff is going out of there. So you have to have algorithms that now sort this out. And that's really the beauty of some of the work that we're doing to make some sense of all those little snowflakes that are coming from that live streaming data, putting some sense to it. So it's very, very exciting. That's really what it's all about.
Ellen, I'll start with you on this question, and that's about the future of the program that you've been working on historically and at present. What do you see for the future of the program in the coming year, 18 months?
I think everything's moving toward more mobile solutions. So I think, we're doing barcode MedAdmin using the phones, but I think there needs to be more ability to do easier documentation on the phones to allow more and more of what clinicians document and orders done electronically. So I think as alerts and alarms, we'll just have to manage those requests as they come in and have solid governance. But I would like to see the EHRs catch up a little bit on the mobile side to allow more things to be done easier on those devices.
Anybody else?
Sure. So I'm going to use a term that I've been, starting to use, and I really liked your air traffic control slide. Where we're kind of heading, people talk about AI and so forth. I have a little bit of a problem with the idea of AI. I think it's going to be, quite a while before we have machines making decisions for us and whatnot. So I like the term of what we've all are trying to do here, and Ellen, pointed out as well, is the instrumentation of healthcare, so that at any particular time, whether you're home in your environment and you need to see where you're at any particular time, or you're in an ambulatory environment, or you're in a ICU, high acuity environment, that both the healthcare provider as well as the patient and the families, have a really good idea of where your health status is at any given time. And it really relies on, technologies outside of our, our current EMR environment. And like I said, those technologies are being used very well by, folks at, Facebook, Google, Yahoo, and Twitter. So I'm really looking forward to, contributing to the, instrumentation, if you will, of the healthcare environment.
So I would say that data sharing is going to become more prevalent, in the next 1 to 3 years. And I think that's important for many reasons, but with respect to certainly algorithm development, having, a larger repository of data to use to do your algorithm, training and testing and training is going to make the algorithms better. It's going to allow us to create algorithms for things for which a single institution may not have enough data, to be able to do those kinds of analyses. It'll help us to, compare what we're doing and how we're doing in different areas, and to learn from the other hospital that is maybe doing better than us in a particular area. So, we're already seeing that kind of sharing at the UC level between, our sister organizations. And so, I'm hopeful that will become, more prevalent as we move forward.
So I'm not quite as jaundiced on the artificial intelligence horizon as Charles. I think we may be closer. So let me just give you a couple analogies. So how did Watson get programmed? Watson read the entire literature, right? And programmed that all in there. But how many of those reports in the literature were accurate? How many were retracted? How much of that was old data, wrong data? And how well does Watson deal with really getting the source of truth? That's a little problem with Watson. But there are newer, what I'll call artificial intelligence algorithms using machine learning algorithms that are able to ferret out what's higher, more reliable studies, and then you can, let's think about using genomic data. You can all get 23andMe right now, or and that's just a little part of the DNA train. Pretty soon we're going to be able to know what's the likelihood that this particular person is going to get Alzheimer's disease. What's the likelihood that this person is going to have some other disease status. We can right now, using our Fitbits or Mac watches, which have little accelerometers and so forth, get a little ping to our cell phone that would say, Dr. Wilson, I see that you have just taken a nice jog. How do you feel right now? I notice that your heart rate is up a little bit or something. Fine, okay. But it could be a different patient that, oh, I notice you're twitching a little bit. Did you take your seizure medication today? To a patient, right? So, and then, so that's just simple algorithms, but then you can have learning by this Fitbit watch that's on this particular patient that happens to have a certain twitch pattern prior to a grand mal seizure. It can go to the smart home computer or a central repository or EICU backbone that I'm kind of envisioning, and then ping that person, say, and now it's going to be a little bit of a higher likelihood of worry rather than just the fact that somebody is getting some sort of vibratory massage data, which is a different pattern that would be going. Does that make sense? So I think there are some things, and I know everything that I said Charles knows at a much higher level than me actually.
All right.
But no, seriously, in terms of what is out there and what's going on. But those are interesting thoughts, and those are things we can do right now.
Thank you. Really interesting discussion. We could go on, and I've managed to leave only